Hello.
Hello, everybody.
Yeah.
Hi. Very nice of you to join us today, and welcome to our webinar. My name's Claire Cordeau. I'm from Simulate Corporation. I lead the healthcare team here, and we're delighted to have you with us for this webinar. I'm so pleased to be able to welcome Dr. Paul Schmidt to the webinar, and that he'll be speaking about managing emergency care, unscheduled care through the hospital. When I first heard him speak about this, I was very excited that somebody had managed to really effectively create a whole hospital model to inform important decisions in the hospital about how to improve the flow. Not only that, but also running the emergency department at the same time. So Paul is a hero in my book, and I'm so pleased that he's been able to get away from a very busy schedule this afternoon in the emergency department to be able to speak to us. If we can just go to the next slide. Just a couple of housekeeping points before I pass over to Paul for the webinar. If you can set your audio to mute, as you can see in point 1 there, it just means that if there's any sound off, then we don't hear it on the main webinar. If you would like to ask a question at any point, then please just use the chat panel on the right-hand side of your screen to ask the question, and then we'll pick that up at the end of the webinar. If we don't get time to pick it up, we will certainly pick it up with you individually afterwards, and we usually also continue the conversation on our Simulating Healthcare LinkedIn page so that more people can join in with the discussion. This recording will be available also on simulatehealthcare.com, so if you have colleagues who wanted to listen to it who missed the session, then they're very welcome to go there and pick it up. So I think that's all that I need to say. Thank you very much indeed for attending, and I'm going to hand over to Paul now with many thanks for this very exciting webinar.
Thank you very much, Claire. I do really appreciate the opportunity that Simulate has given me to talk about the work that we've done. It's always nice to be able to share some of the lessons that we've learned and some of the reasons that we did it, the sort of problems that we're struggling with, which I think we're probably not the only hospital either here in the UK or elsewhere that's struggling with the same issues. So in terms of just giving you an overview of how the discussion will unfold, is I will give a bit of the background to why we did it, what our thinking was that informed our approach, and how we then launched upon using simulation really as a really key part of the process of making some sense of what we need to do and resolving a challenge, and giving us the confidence really to move on. And I'll share some of the outcomes from that. Obviously it was a very large piece of work over about a 2-year period. I started in 2012 with a project manager, I had a business analyst that helped me with the analysis. It was a project sponsored by the now defunct South Central Health Authority. So what I'm presenting here today is really just a snapshot, and as Claire says, if anybody wants to have more information, I'm very happy to talk about it. So I appreciate we have listeners both from the US, good morning, and the UK and elsewhere, and good afternoon to you. People may be familiar with who's familiar with the NHS might know that Portsmouth Hospitals is one of the very large acute trusts, probably one of the top 4 or 5 large acute trusts. We've got a very large catchment area of about 600,000 patients, leading to in excess of 100,000 emergency department attendances. I say in excess because it's very difficult to keep track from month to month. Every month we seem to be hitting a new record. We've had some annual increases of up to 11 to 12% here, and there are various reasons offered for why this demand seems to be going up handover first. That leads to about 40,000 inpatients, of which about 25,000 patients are medical, which is where I work as an acute physician. For those in the US, acute physician, the closest I think to your setting would be a hospitalist. So I'm not an emergency physician by training, I'm a physician by training, and we focus on the first 24 to 48 hours of the patient's journey to try and improve the care to the sick general medical patients, unselected general medical patients. In 2010, our department was put, our acute medicine unit, or medical assessment unit as it's known elsewhere, was put into the same management structure, a clinical service center, as the emergency department, and that was a stimulus. So though we've still maintained separate clinical directors, that was a stimulus for starting to think about perhaps making more rational use of the resources that we've got. Discussions with staff and feedback from staff surveys suggested that people felt that there's a lot of duplication going on, but not entirely sure how to resolve all of that. And of course, we're all aware about how the challenge is building up and changing at the same time, probably in line with many other industrial countries. Trauma and injuries are of decline. That was the original reason why emergency departments developed from the 1960s onwards, and increasingly these departments are have got frail elderly and patients with chronic medical comorbidities who have now deteriorated resident in these departments. There are also patients, of course, who are exercising a choice of coming to the emergency department rather than the general practitioner, and of course it is the last port of call, or actually the first port of call probably, for those with all sorts of problems in their lives, range from mental health issues through to alcoholism and substance abuse, etc. So there's a whole range of reasons, and of course the alternatives depends on the type of problem that you've got and whether or not those alternatives are available. All of the above leads, especially since the 1990s, the whole concept of emergency department access block has been recognized, and in the last 10-15 years in the UK there has been a development of acute medicine, which has come to work alongside the emergency department in as I said, trying to create a better organization and safety to the care of patients in the first 24 to 48 hours of care. The emergency department used to look, in the UK, used to look after patients within the first, say, 24 hours. We're very used to having patients on trolleys, but since the 4-hour wait come in, their time window is reduced to 4-hour, to sort of 4-hour window of giving care. And the question is whether or not all these various developments, whether they've actually helped or hindered, and whether or not that's actually led to more or less continuity of care in the first 24 to 48 hours. Our sense of it is that there is more complexity, more confusion, and perhaps more complex patient journeys. And so given the opportunity to run this project and kind of do a bit of blue sky thinking and trying to come up with a blueprint for a new operational strategy was an excellent opportunity to jump at. And I think this has probably originated from the US because it mentions Medicaid beneficiaries, but I think this is still a good representation of a sort of service transformation model, looking at the inputs on the one side, and the outputs on the other side, and I think the inputs are very clearly capture what I've just, the different patient groups that I've just mentioned. So I think that's still current. The bit that I don't recognize really is that it just refers to the emergency department, and of course we recognize that patients come into the hospital with unscheduled problems. Any care that is not planned ahead, or any chronic disease, or even chronic disease plan management that is not planned, we call unscheduled care. Now, a lot of unscheduled care is, of course, provided in the community, but when patients are sick enough or by their choice, they present themselves to the hospital, then that's the system that concerned us. And the interesting thing is that when you really look at the literature, and I've had the opportunity through this project to look at the literature, both the emergency department literature and also the literature for acute medicine units, people tend to look at any interventions and service reorganizations in isolation. So you never quite get the sense of what is the other context that a service change has happened in. So people tend to tinker around with changing and making interventions within their own department, right, either the medical assessment unit or the emergency department, but rarely do you actually get a sense of how the whole system works. And so, for example, emergency departments have introduced observation wards, but you could argue, and if you look at the literature, there are different observation wards. Some observation wards in the emergency department are run by acute physicians, and equally you have short stay wards such as the medical assessment unit in other health systems that are run by emergency physicians. So there tends to be a whole mishmash and overlap of these things, and it's very confusing to know. And there is no shortage of external advice virtually every other week for what we should do in order to make a change, and by and large usually it involves opening yet another type of service, and you kind of question the validity of all of that. So what I don't recognize about this picture is that it does not include the patients referred in by the GPs and so on, or the patients that we've seen in the emergency ambulatory care these days. So it clearly needs some update. So talking through and thinking it through, reading the literature, one could, nowhere in the literature does it really, do people really try and get a sense of overall demand on the system and have a demand-led assessment of how the service should evolve. It seems to be very focused on what clinicians think should happen, and of course clinicians are influenced by their own biases, their own anecdotes of how they their favorite anecdotes, how they say the system should work, and in the back of their minds always, we clinicians will have in mind how would it affect us. So we're perhaps not the most unbiased to be involved in system redesign, and it has ended up, I think, rather more by accident that we've ended up with these emergency department and an acute medicine unit right next to each other as a end result of what the physicians wanted and how they want to work. So we ended up with a functional divide, with a lot of operational efficiencies, with all of the resultant symptoms of the sick system that we probably all recognized. Now, before I go on further in the discussion, it would help, I think, just to get you thinking around some good operational design principles, especially regarding queues, which seems to be the bane of our lives in this sort of area. And there's a couple of key rules to keep in mind. The first thing is that we should always think about how we can devise our services so that they are focused around customers with similar needs. This was done very successfully in the emergency department in the UK in around 2003 with the 4-hour initiative, National 4-Hour Project, where they got rid of something called triage to replace it with streaming of minor patients with minor problems to services dedicated to them. And they made, the reason for doing it is on this slide, and definitely had a significant impact on the success of that particular project, and has led originally through that course of that decade to most emergency departments achieving seeing 98% of their patients within 4 hours. Of course, nothing stands still, and even though most places still run that, with the demand increasingly going up, one could view it that maybe it's a change and a redesign that's left incomplete. The other design principle is that you should try and pool the people who are going to process the demand as much as possible, because the more processes you've got, the more likely that somebody is going to get stuck at some point in a queue behind somebody who needs a lot of attention. And that, of course, would lead to the queues going up. So the next 2 points on the slide is very related in the points that they're making. Again, the idea that if you have a factory that, for example, makes buses and cars and bicycles, if there's a demand for a lot of bicycles but the factory is making a bus, then probably there's going to be a long wait before the bicycles are going to get made. So, and the same thing happens in emergency departments. If you've got very sick people needing a lot of work, then that's going to that increases the service time variation if you've got people with very different needs in the same queue. If you can address your service redesign in a way that similar patients go to similar services, then that will improve the efficiency with which your staff are working. But you can only push it that high, because if you push it too high, then you could reach a situation where if staff are really working to the hilt, that you can have explosive increases in your queues very suddenly. The last principle to keep in mind is the idea of a cutout. Now, a cutout is where you set aside a service so that you can pull specific patients in, which obviously goes against the idea that you should have more pooling of people that are processing the demand, and you really shouldn't use it if it's justified. And I will, in the further discussion, I will refer a little bit more to this. We'll come back to this issue. So back in the 1990s, people were prioritizing, as I mentioned, and triaging, and they realized actually that's probably a technique that is more suited to the battlefield where it originated, because really you should only be applying triage when you've got an under-resourced operation, and it's not really the right way of designing operations. You should really design it to be able to cope with the demand. And so a better approach was developed in the form of sorting, which sorted the well patients from the sick patients, and because the well patients by and large leave the system, they tend not to be admitted, that means that there are fewer of them around, so there's less work in progress going on in the emergency department, which frees up the staff to deal without distraction with the sicker patients. Now, patients' journeys can intersect and compete with each other at many different times, and the more times patients get transferred from one clinician to the other, there's more chance of these intersections happening. So if we just imagine looking at our medical system that we're running, with patients being admitted from the emergency department through to the acute medicine unit, and from there on we do another round of sifting and sorting and decide which patients should be short stay, which we try to keep hold of on the unit, and then move the longer stay patients, usually patients who we think will have a longer than 48-hour length of stay in hospital. We try to move them on to the specialty medical wards, and we try to pick the most appropriate specialty. And of course, some patients will end up being outlined. Now, if we just imagine a situation where I've got, oh, I might have just, okay, sorry, there's a bit of a glitch on the slide, but anyway, where I have a couple of sick patients, a well patient in the ED, and a patient referred by the GP. And at the moment, I have just got one bed that's opened up on the medical assessment unit. If I give that bed to the GP patient, the patient with a GP, then of course the sick patient is being blocked from getting through to via the acute medicine unit through to the medical unit. The rather well patient in the emergency department who may just need an overnight stay or perhaps a bit longer monitoring, perhaps for another 10 hours or so, that patient is still stuck in the ED. So there I've caused access block. And of course that patient coming from their GP will take a few hours to get there, either because they're making their own arrangements to get in and packing their bags and getting their own transport, somebody to bring them in, or because their GP has arranged for them to have a urgent ambulance journey, which means that they kind of second-class citizens in a sense, because the 909 ambulances, of course, are under instruction to take any 909 call is instructed to take patients to the emergency department. So the GPs would sometimes, if it's very urgent, you know, they would call a 909 ambulance to send the patient into the emergency department, even if it is a medically expected patient. So if I allocate the patient, if I allocate the bed to a sick patient, which probably would be the most rational thing to do in a one way, but under the understanding that I don't know how sick that GP patient is, then what will happen probably as night follows day is that the queue which is unmonitored, the GP queue which is unmonitored, will be growing. The emergency department queue is under very close monitoring all the time to see whether we're breaching the 4-hour wait, and therefore what was going to happen is the perverse incentive therefore is that eventually these patients, GP patients, are going to be referred into the emergency department, so they'll just join the back of the queue. If I make the decision that actually I'm going to if I do take my well patient onto the medical assessment unit, and there is more demand coming behind, like sick patient in the emergency department and a GP patient in the emergency department now, then that very well patient, who I should be keeping on the medical assessment unit to discharge them directly from the medical assessment unit and shorten their stay like that, that patient is probably going to be the one that's going to get outlined overnight when there isn't any beds. So you can see the end result is a lot of perverse flow that is happening in the system, where my GP patient has now ended up in the emergency department, I've got all the sick patients in the medical assessment unit, and the patient I would like to get out of the system quickly is now an outlier on somewhere, and will probably have an extra day or two increased length of stay, just adding to the work and progress in the system. So once you start looking around, there is absolutely no problem identifying lots and lots of waste in the system. And the 7 deadly sins of lean, we've got them all, and the question is, how do you design these problems out of a well-functioning emergency care system? So in starting the conversations with the various stakeholders, you quickly realize that while everybody wants the same thing, they probably want it slightly differently. They emphasize different things. So from the executives, they've got governance concerns, financial constraints that they're battling. they have to ensure that they protect the reputation of the trust and don't end up on the news every night because of queues and of ambulances outside the emergency department. Patients, of course, is most important. This is the group why we're here. Their needs are actually in some way quite simple. They just want to trust that we will do the best for them. They have come to us because they feel they can't wait for whether that's right or wrong, and whether it's an interpretation or whether they're really sick. What they really want is that they don't want to wait. They want to receive good quality care they can trust in, good communication, and above all, one of the things that people say most to me and to my colleagues is whether or not, if you've seen them in the emergency department or you've seen them on the medical assessment unit, whether I will see them again the next day. And unfortunately, most of the time we have to say, no, it's probably going to be somebody else who's going to look after you again. So we really do not have this continuity thing sorted out. And so in fixing all of this, we have to think of how to develop an operational strategy that can achieve perhaps fewer moves for patients, try and put Humpty Dumpty together again in terms of good continuity, simpler processes, getting rid of the waste, getting patients out of the various departments with work and process, getting them out quicker, and just working out whether or not at times we are overburdening staff, which then leads to the queues, and how to get the staffing better sorted. From these various discussions, the key concerns, of course, became apparent very quickly, and that is people are really stymied by this flow issue. Why is there not flow? How can we make flow better? Is it a capacity issue, or is it more to do with how the processes work, and that is not a capacity thing? How much does staffing rotas contribute to the capacity constraints that we've got? And of course, whenever you're talking about making wholesale change, people start getting worried about their jobs and what their jobs would look like. I don't think people are really, there's any emergency physicians or even acute physicians that are worried about going to sit on the dole. It's more that they are there because they like the kind of job which involves a lot of variation on a day-to-day basis. Every day is guaranteed to be entirely different, and they are there because they like that. They've definitely avoided jobs like subspecialist jobs where they'll be seeing the same kind of problem all the time. So they need to be reassured that whatever you're going to do is you're not going to reduce their job satisfaction. They buy into the fact that we need to try and solve the problem we've got, but obviously from their perspective, not at any cost to the staff. Right. So the approach we took is a very sort of data-centric approach in the first instance. We felt we needed to understand what demand looked like, both in terms of the hourly demand by day of the week and by hour of the day. We needed to understand what the needs are that patients present with. How can we categorize these patients that captures their needs in a way that we can understand how that need then impacts on the hospital? How long do patients then stay in the hospital? Can we follow them through? Can we follow all of their journeys through? So to start off with, we took a whole year of data for our trust, a whole year of data for the emergency department, a whole year of data for the ambulance service that transports the patients here, and we stitched these three databases together to form a single so that we were able to track a patient's journey all the way from the time that they called an ambulance, or that the GP called into the hospital and said, I want to refer the patient. We had access to those logs, and we stitched the whole thing together so we could follow the journey all the way through the emergency department, whether they left the emergency department there, or whether they came onto the medical assessment unit, left there, or whether they went on to the medical specialties or were outlined and then left the hospital. So we had the whole thing, and we had a whole years of data to work with. So from that, some of the following slides that I'll show will show some of the insights that we developed from that. Then the next step of the process is to come up with a coherent redesign, which addressed all of the key things that we wanted to make sure is addressed, so we don't have a piecemeal focus on either one thing or the other. So we wanted to make sure that patients had more reliable and more clear signposting for where they needed to present themselves, easier streaming. And when the patients do present, that they need to present to the right skills. So the staff who are going to process them actually have the skills related to the problem they present with. It's no point in me seeing a patient when they're presenting with trauma, because I'll have no idea. And we have to think about how we will simplify these processes to cut out waste. The concept of co-production is the idea that somebody like Clayton Christensen has talked about a lot in his book, The Innovator's Prescription, and he specifically refers to hospitals as well as a good example where patients get moved around the system to see various specialists. Is it possible to turn that model around and to say, well, actually, why don't we bring the specialists a bit closer so that we don't have to move the patient around that much? Maybe that will be more efficient. And so the way we thought about it was that we want to bring our emergency physicians and our acute physicians together in the same area so that we could both support each other in the workload, but equally perhaps have more face-to-face conversations about working out what the right journey is for the patient onward. And from that, hopefully, will lead to fewest number of transfers, and we need to think about how we'll synchronize the flow, and I'll get to some of that a bit later. And then lastly, the key thing is that this will all be good in theory, but how will we actually prove that it will be better? And for that, we needed to be able to test the designs, and the idea of creating a huge, big Excel spreadsheet, which somehow would convince my colleagues and the operational managers and the executive was definitely not on the cards. I had some previous experience of simulation, not a great extent, but I'd worked with some people, so I intuitively thought that testing this with a simulation would be much better than my intuition about where we should be heading with the blueprint. And we needed to think through some of the key performance indicators we would use to judge whether or not it would be better. So starting off with what we've already observed, we thought, well, it's clear that patients presenting with trauma have different needs, and we'd already made some other observations that seem to suggest that trauma present at a different time of the day. It's more likely to present in the daytime, medical problems more likely in the night time. Ambulance use is more, well, the the medical patients or the non-trauma patients are more likely to use ambulances. So it seemed natural to look at demand cut by whether or not patients have presented themselves in an ambulant fashion or by ambulance, because again, patients who come here by their own transport are exerting a choice, and you could argue, well, could there be another way to provide that service? Whereas usually ambulance transfers are less easy to divert elsewhere. So it seemed logical to look at our demand and our hourly demand in that fashion. And immediately it became apparent what we had suspected, and that is that the non-trauma patients, the sicker non-trauma, which include medical and potentially surgical patients, frail elderly patients, arriving by ambulance, is the group that really is overwhelming the service. And I think the other groups, like the trauma patients and the patients arriving with their own transport with non-trauma problems, are probably caught up in the system more than anything, and if we could sort out the non-trauma, sick non-trauma patients arriving by ambulance, then these other patients would probably get out of the system more quickly as well. So the question was how we could meet that demand with these sick patients better, because you know, one of the things that we've realized through a few trials was that when we do, as acute physicians, go into the emergency department, we can base ourselves there. We actually do turn probably about 15 to 20% of the patients that would have been admitted, we turn them around in the emergency department, just for a lot of different reasons. Partially because it means that you're bringing a resource forward, so there's a bit more time to sort them out within the 4 hours. The other is perhaps you have a bit more confidence. The person before that might have referred the doctor before that might have referred the patient for us to see as an admission might have been the emergency junior doctor. We just probably have a little bit more experience of this, and more importantly probably have got links into the various specialties that we can potentially plug the patient into. So so thinking through the problems I've already outlined and these perverse flows, we thought really what we want to move from is a 3-stage process where patients have to travel all the way through to get to the medical specialties. The patient have to be admitted from the emergency department through the medical assessment unit and to the medical specialties. A short stay unit would allow us to keep hold of our short stay patients hopefully without people ending up outlying them, and so we can really play the role of selecting out those patients who definitely are short stay, who shouldn't stay within the hospital, and try to make the service for them really focused on their needs and get them out of hospital as quickly as possible. And usually that involves more rapid investigation. Sometimes it may involve, you know, overnight intravenous fluids or initial few courses of intravenous antibiotics, and then they can be converted to oral antibiotics and then out. And we have got the ability through our ambulatory emergency care clinic to bring those patients back. And again, that's one of the reasons why, if we are based in the emergency department with our emergency colleagues, then because we've got access to the emergency ambulatory clinic, we could direct patients to that for follow-up rather than admitting them necessarily. So there seem to be good, solid reasons for introducing a merged or integrated acute care hub, which then we try to have a consulted decision prior to admission, whether it's the emergency physician or the acute physician doing so, to direct the patient to the right care area, onward care area. So, using our data set that we created, our year-long sample set, we looked very closely at how patients move through the system, and because of the model that I've just showed you, we looked at the chances of them staying less than 4 hours with the condition, 4 to 48 hours or greater than 48 hours. And so we had built these groups. We had built up a segments, if we call it segmentation, of about 16 different groups. We could have cut it differently, but it seemed, looking through the type of problems that people presented with, that this was going to be good enough. We needed something simple enough that people could get their heads around, with not too many categories, not too few, and this seemed to work well and linked to the ultimate specialties that people might end up with. And what you can see as, by and large, and though there were different patterns, by and large, patients arriving by ambulance were going to stay in the hospital longer. That effect persisted beyond the 4 to 48 hour period, and even played a role as to whether or not a patient would stay longer than 48 hours or less than 48 hours. So it seemed to make sense, therefore, to make a key operational focus for our redesign how patients come into the hospital, whether they walk in or whether they come in by ambulance. And that is a big departure from the system we try to operate at the moment, which is if you have called your GP first, then you have to come to the acute medicine unit. If you have elected to pick up the phone and call a 999 ambulance, then it's okay for you to come to the emergency department. Now that has got a lot of problems with that, because it actually creates a lot of inequity. Because from that moment onwards, the patient that has picked up the phone as instructed by the NHS, picked up the phone to their GP, is from then on persistently kind of discriminated against in a way by the way the system works, because they will now wait to see their GP. The GP will have to come and see them perhaps. Then the GP will call us. The ambulance, if they need an ambulance, the ambulance will get them here slower than for the 999 ambulance. If they have to bring their own transport, they'll be even longer before they get into hospital. They are less likely to have their x-rays on the same day, and they're less likely to see a consultant on the same day than somebody who's come through the emergency department. And equally, you've already heard that they end up, a lot of patients with, because of this, a lot of patients have worked out, actually, you know what, it's actually easier just to call up just call 999, or just bring myself to the emergency department. So that whole system just doesn't work. It causes it's a bit like Moses trying to keep the waters apart. It just doesn't work. We've got an immense investment in operational managers trying to make sure this works, but it just doesn't work. And from my perspective, if we're going to simplify the system, let's move to a patient needs focused approach rather than something that's invented by the system. So from my point of view, I think we should ditch this whole operational design based on whether you've called your GP or not. Very often the ambulance crews have got reasonable discretion about whether or not they will leave a patient at home if they don't think it's serious, or to transport the patient to the emergency department if they think it's serious. And very often the ambulance staff do very good assessments, and so it's not as if patients arrive in the emergency department unassessed. So putting all of these various thoughts and concepts and aims of redesign together, we've come up with our view of what an integrated model should look like. So it would be three services sort of running almost in parallel, and you have the sort of trauma injuries stream or focused service, and then you have a service focused on the just catering with ambulance admissions for patients who do not have injuries, and then lastly the ambulant stream. And when we have plotted through all of our various patient journeys from that year's worth of data, according to the 16 different categories that we created, we now have a very good view of what the type of problem will be that we will see in each of these focused services. And therefore we can now align the staffing and the skills within that service. So for example, if we looked at the ambulatory unit, clearly we will probably have to have an acute physician there, an emergency physician, and perhaps even think about having a GP in there with who's interested in more unscheduled work. I mean, a lot of hospitals in the NHS have developed urgent care centres as well, and the whole idea of an expanding ambulatory service is quite exciting. The surgeons over the last decade or so has been extraordinarily effective at moving a lot of their inpatient care into day surgery. And I think there is a similar revolution possible with ambulatory care for medical type patients. Now, in order to achieve that, one of the things that we really do need to negotiate is less strict adherence for these patients with the 4-hour wait, because we very often, if a patient comes in, they may have a CT scan, they may have a blood transfusion, they may have acidic drains done. Sometimes they're here for 12 hours, but we pack into those 12 hours lots and lots of different tests which previously would have occurred over a 2 or 3 day window. Patients are very often, because we've got the facility to manage it, the patients are very keen often to have these investigations, go home for the evening, to sleep in their own bed and come back the next day to complete it. So it does seem to work for patients. So I think there's a lot more that we can achieve with an ambulatory service that's been developed to full capacity. If patients do need to be admitted from an ambulatory unit, they will move. The idea is that they are more likely, as you can see from how the streaming works, that they are more likely to be admitted to the short stay unit than to either the medical or surgical specialties. We think that a correctly selected patient population would probably have about a 10 to 15% conversion rate. We're aiming for about 15% conversion rate. By conversion rate, I mean that a patient would then, after receiving ambulatory care, they may still need to be admitted overnight for a stay, because we just couldn't get it all to work in the ambulatory care stay with, or because the patient is actually sicker after assessment than we had originally believed. However, the ambulatory unit has, and our experience of it is that it's grown hugely over the last few years as a means of managing demand. By positioning the consultants, both the emergency department and the acute physicians, within these 3 services, or actually jointly in these 2 services, we can work out what is the best disposition for a patient. So if a patient does arrive by ambulance, and we do assess, even just as the patient comes into the hospital, that actually the patient can get out of the ambulance, can actually walk in, then we have the option to push the patient right over into the ambulatory clinic, and to avoid having all of that demand within the ambulance transport area. And equally, if the patient is assessed arriving by own transport into the ambulatory area, though most patients will be appropriate to that area, the odd patient may need to be taken on to the non-trauma assessment unit. But by and large, you can see that the injuries stream have very little cross-streaming or intersection and moving over into either medical or surgical wards. Most of the patients that are in that stream will, if they will have to be admitted, and very few of them really do have to be admitted, they will either have quite a short stay on the trauma observation ward, or they will be admitted to a trauma and orthopedics ward. And the reason this separate stream is quite important is going back to the idea that if we cohabitate with having acute physicians and emergency physicians cohabitating within a single area, then we shouldn't have patients in there who don't need my skills, for example. Okay, so that gives you the background. Now this has to be tested within a simulation to see, this is good in theory, but will this actually be practically lead to improvements in flow, and is it deliverable? So the key performance indicators that we thought we would need to measure the system overall is on the slide. The key ones that I've highlighted in red are the ones that we were going to use within the simulation modeling to calibrate the model. So once the models had been built, we would calibrate the models against real data from the hospital information system to see how accurate the model is actually representing the real system. And then we could look at the other metrics, the KPIs in black, to see whether there is improvements in the way that the system is functioning. So our initial model that we built, we simply focused on getting the emergency department and the acute medicine unit properly represented, and it was what we call a free flow model. Therefore, there was the specialty wards that did not represent any constraints. So once a patient left either the ED or the medical assessment unit to the specialty wards, the model simply counted to see that the number of patients going to these various areas are actually correct. And we were just concerned with getting the various steps within the ED and the MAU correct. And as part of doing this work, we also have the business analyst going out and doing time and motion studies to see how long does it take a nurse to do an assessment, how long does it take a doctor to do an assessment, and what is the variation around that, so that our model, we want to try and populate our model with as realistically sampled information as possible. So in feasibility testing, we only focused on the first, and so we haven't yet looked at the whole the whole system. We were just looking at the initial stage in the emergency department, and we were gratified to see that when we looked at the emergency department length of stay, that we were able, that our simulation of the real system was actually really accurate. So if you look at the average, the real system was doing it was 2 hours and 38 minutes that patients spent on average in the emergency department, and we were able to achieve with the simulation, we were able to achieve exactly the same. And the new system seemed to perform better. We saved some time on average. You will notice that the simulations, which are represented in the dotted black line and the red line, seem to show more variation than the actual system does. But what is interesting and reassuring is that where the troughs occur in the real data, we have troughs, and where the peaks occur, our peaks coincide in the simulation. So that gave a lot of confidence. Looking therefore at why that is, you can see that the real data for length of stay and the simulation data, the profile looked quite different. And though it troubled me initially, I don't think I should be troubled by it. I think there's two things to bring out from that. The first is that clearly, because our data is based on real assessments and variation of assessments, if you look at that long tail in the simulated data, actually it tells you that there's real work there that needs to be done. The simulation cannot work faster or slower. It only works at a single pace. And the other thing that we haven't really done within the simulation, we haven't really done multitask. We haven't got staff to multitasking and interrupt themselves. And I think that very likely is the explanation for what happens in real life, is that actually staff probably have a few patients on the go at the same time, and it's only when they approach the 4-hour time limit then they suddenly complete on a number of these and get the patient out the door. My worry is, and what we do see on the acute medicine unit, is actually that because that there is a lot of work, that staff are overwhelmed, even though they speed up, that actually there is work that is left undone when they come through, and you can see that that dramatic peak at 4 hours in completed patient journeys probably represents when the operations manager is just pushing the patient with a trolley through in order to beat the breach. And so that data is reflected in the same way, in a slightly different way, as a cumulative plot. And you can see how, on the real data, you can see how people suddenly start to work faster and harder as they approach the 4-hour limit. But you can also see that the simulation of the real system predicted that actually, if they didn't do that, that actually the work was there to be done, and we would actually have more breaches otherwise. But satisfyingly, the integrated system would lead to quite a big reduction in the number of breaches that we would see. So it looks like a more efficient system. And this just makes the same point. Part of the benefit is that we're sharing the workload, so the time to the doctor assessment we'd expect to virtually halve. The number of patient transfers that would need to happen will reduce by almost 17%. Now that, to give you an idea, that's the equivalent of about 6 hours of corridor time that is taken out, which now all that corridor time where patients need to be moved to other beds probably end up in the emergency department queue. So if we can take 6 hours out by reducing the number of transfers, then that's a big gain. And we can see that wherever the patient's end destination is, it will be more efficient. If you look at the top of each of these graphs, you can see a very small little dot at the top. That represents the 95% confidence interval for each of these differences. Now the interesting thing is that even where patients are going to go straight home from the emergency department, or even if they have a non-medical admission, i.e. though we are a position in acute physicians within the emergency department, the improved efficiency means that the non-medical admissions get dealt with more efficiently as well. But clearly the biggest changes are that the short stay ward will function more efficiently, and the patients will get to the specialty wards far more quickly. The interesting surprise from all of this was, which I hadn't really thought about before until we looked at it and developed this graph, was that actually we would achieve flow synchronization. Under the current system, which is represented by the dotted line, you can see that when we do we batch the patients. So the patients come in through the emergency department. Those patients need to be admitted, come to the medical assessment unit. If we can't see them before we leave at 8 o'clock in the afternoon, in the evening, we come back as the consultant team and we post-take them the next morning. And you can see the effect of it is that they suddenly, as we're post-taking the patients from about 8, 9 o'clock onwards, there is demand for specialty beds that occur. And that persists throughout the day, that we're ahead of where the supply curve is. So the supply curve of specialty beds is formed by when the patients are being discharged. And you can see that only about 50% of patients are discharged by about 4 o'clock in the afternoon. Now, if we move to an integrated system, the time when a specialty bed would be demanded, that curve would move much closer to the supply curve, which means that we only have to become a few hours more efficient. We just have to move that specialty bed supply curve to the left by 1 or 2 hours for these two to coincide, and that would then mean that we've got synchronized flow. So as the demand builds up during the course of the day within the emergency department, we would have the specialty beds being able to free up beds just in time. So another sort of lean concept of just in time to receive the beds. So the summary of the results are that we've achieved quite a bit. One of the points that I haven't outlined or highlighted yet is that the doctor's workload being shared, and because rework is reduced, will be equivalent to having about 2.5 extra doctors. Right. So people said, well, that's all fine and great, but you just need to hang on a minute before you get too carried away. What you haven't done, and our experience every day, is that we can't get access to the specialty beds. it sounds good in theory, but can you prove this? Therefore, we were sent away to enhance the modeling by now including the specialty, the representation of the specialty beds, so that we could model the impact of the constraints imposed by the specialty bed supply. Of course, we think there might be a good impact in terms of reduced transfers and because of synchronized flow, and also we haven't yet played around with optimizing our staffing rotas within the emergency department and the medical assessment unit. And I'm not going to present any of our work around the staffing. We did lots and lots of work around staffing optimization, and clearly that led to a completely different answer. But what is great about simulation is that it can allow you to ask the questions in a slightly different way than you would normally do it. Very often, people end up imagining the hospital, building the hospital, therefore have already achieved the fixed bed capacity, and then try to work out what their staffing should be in those services. With simulation, you can actually turn it the other way around. So here is the fully developed model, and so when I'm asking those questions around both around the process and the staffing, what I can simply do is just set all of my beds to very large, so that beds are not a constraint on the modeling of the system. And the only thing that would impose a constraint is if I don't have my staff on at the right time of the day in the right place. So that allows you to optimize your staffing first, and then you can start to shrink your beds down for each of the areas, and then start to see where does the constraints start to come in, where does your queue start to build up. So it allows you to really tease these things apart in a way that you cannot do in real life. But the last thing that we then worked on, so we worked on staffing, and then once we optimized the staffing and we reduced the number of queues we had, so we had no queues, with the right staffing, and it didn't mean more staff. In none of what we did we required more staff. We just needed staff at the right time of the day. So changing rotas is more what we're talking about rather than more staff. But then once we did that, we were able to then look at the bed capacity, and Simulate has an output which allows you to look at each of the areas to see how would your beds be used. How many beds would you need at different times of the day? Now, as you can see within the emergency department, the 4-hour assessment cells, there's huge variation in how well they're utilized. And there's slightly less variation when you go to the short stay wards, but again, the numbers or beds required varies still significantly relative to the number of beds. When you move down to the specialty bed requirements, you can see the variation is less. So, for example, the elderly department, medicine department have about 180 beds, and the variation around that is relatively small. So this is a great way of visualizing where you need your beds and how your beds will be used. So from that, we were able to work out that we needed to expand our 4-hour assessment cells. So a big fat pipe at the front of the hospital, and we're actually, our current utilization, bed utilization or care space utilization is about 43%, and we think it should be pushed down further to take into account these huge variations, hour by hour variations. When you get to the short stay beds, we're utilizing the bed space on the short stay ward better, but we needed fewer of them, so we were able to reduce the short stay bed provision on the acute medicine unit by 17 beds, and we were able to push that through to the specialties, so that by approximately the same number, so that the overall bed number stays approximately the same, but we're actually achieving we're achieving better use of our beds. So it would be the equivalent of having an extra 10 beds in the system. So the efficiency improvement is equivalent to about an extra 10 beds in the system. that we have available. So all things being equal, it should be better. The integrated system should function in a more robust way, being able to cope with the variations and unscheduled demand. So the simulation was a really key tool for us to use, because it persuaded the management, the executive, but also my colleagues that this is the right way to go. They could actually see that we captured the complexity of their day-to-day life in a way that they would not have faith in an Excel spreadsheet or any number of PowerPoint presentations by a management consultant. And the beauty of it is that people were, because it's iterative, we were able to take the simulations back to people to question and to and therefore have confidence that in the answers. And it did help to change everybody's mind from just tinkering with parts of the system to looking to recognizing this is a wholesale change that we need. We've achieved what we can achieve with the current system. Any tinkering with the current system is just going to achieve very small improvements. In order to get a step change in our performance, we have to change the flow, we have to change our staff rotas, we have to then get the beds in the right place in the system. So for those of you who are still with us, I think I've probably run over time a bit, but I'm happy to take any questions.
Paul, thank you so much for that. What a rich picture of all of the work that you've done, and such great insights that I think will have been very well received by people joining us and who are thinking about using simulation in this. We've had a couple of questions throughout, and I think I'll just deal with one now in the interest of time, if that's okay.
Yes.
So one of the questions we've had is, if you were to give advice to someone else trying to do this in their hospital, what would it be?
Yes, a difficult one. I think the first thing is that to try to get the question right first about where you what is the real questions you want to ask. I would definitely suggest, if you want, I would definitely suggest going down the simulation way. I mean, I've used simulation now. Once you become familiar with the technology, it's not very hard to learn. I've been on a course now, and now I very often apply it for small little projects, things that you might not actually think. You might think, well, actually, we can just intuitively solve it. Well, actually by modeling it through, I've created models sometimes within a day or even an afternoon, and it's already given me useful ideas of what the real questions are I should ask. So I would suggest, if you're thinking along these lines, don't hesitate. Ask to see if they're either in your hospital or these days in universities, whether there are people with simulation abilities. I mean, the way my project got started is with a MSc student from a business school who had simulation expertise and used Simulate, and he had a project that he needed to do. So my advice is think in this way, because no other industries outside healthcare would dream of making big system changes without simulating it first. So I would just say, don't be inhibited from trying it.
Okay, thank you very much. That's very helpful advice. I'm going to say thank you very much indeed again to you, Paul, for all the work you've put in. I know that this is a part of a bigger presentation, and you could talk a lot more about staffing, and I really hope we're going to be able to get you back to talk about that in the future. But I think in the meantime you're happy to be contacted by people, is that right?
Absolutely, no problem at all. Yeah,
Thank you very much.
I don't think I've included my email address on the slides, but if people do want to contact me directly, my email address is paul.schmidt, STHMIDT, at porthosp, porthosp.nhs.uk. Or otherwise, you can just approach Claire, and Claire could link up with me.
Definitely, and if we can certainly circulate that to the people who've attended this webinar. So thank you everybody for listening. Thank you again to Paul for a great presentation. We'll be posting the questions up on our LinkedIn site as usual, so please do continue the conversation there. And can I wish you all happy holidays, and in January we'll be coming back with another webinar looking at how to get started with Simulate with University of Toronto, who can get you up and running in 40 minutes, I think. So hopefully you'll join us for that one as well. So thank you very much to everyone. Thank you to Paul again, and have a very happy holiday.